Hi, everybody. My name is Maile Young Karris, and I'm an associate professor in the divisions of both infectious diseases and geriatrics, so I kind of span both. I'm particularly interested in the aging trajectory of older adults living with HIV, and that's my specific research area and clinical focus. But I'm really excited to welcome you all to our panel on physical resilience. So physical resilience, just as a reminder, for those of you who are new and missed the amazing talk that we just had, or just want a little bit of a reminder what physical resilience is, it's essentially the ability of a body to withstand and recover from stress, challenges, or trauma. And I am joined by an amazing panel, so please help me welcome Dr. Ryan Moran, Associate Professor in the Department of Medicine and the Herbert Wortham School of Public Health and Human Longevity Science, Dr. Theodore Chan, Chair of the Department of Emergency Medicine, and the affable Gail Levine. Please welcome us. Okay, so we're going to start with a question. Dr. Moran and Dr. Chen, in your clinical practice, how does physical resilience impact health and health outcomes?
Thank you, Dr. Karris. Well, first, it's really a pleasure to be here this morning. I really appreciate it, and really appreciate everyone making the time to be here. And so physical health resilience is incredibly important across the health span. So I'm a primary care doctor at UC San Diego. I have the real privilege of caring for patients really across the age spectrum, but largely a number of older adults. And I have quite a few patients that choose to have their significant other also as me as their physician, so I'm able to see couples as they go through their life over the course of decades and years. And it's very evident how one thing can happen to someone and how much that can translate to everybody else that has shared environments. And how important it is for physical resilience in particular, how once something happens, people oftentimes don't get back to where they were just a month prior. So also, to really discuss the plasticity of humans and how resilient they can be, but really enabling people to understand, well, just because you are at a certain place doesn't necessitate that it's impossible to change. So hugely important.
Yeah, I just want to reiterate what Dr. Moran saying. First of all, it's a pleasure to be here. Obviously, in the emergency department, we are seeing older adults at their time of the stress, whether it's infection, sepsis, or trauma, or fall. So we are seeing at that time exactly how resilient, or trying to make an assessment of how somebody's resilient. And it affects a lot of things. First, our assessment, because as you get older, actually, the common presentations that you would maybe come with in terms of a septic patient, in terms of your vital signs, they often aren't there. It's other syndromes, like maybe somebody comes in confused, or they're incontinent, and in fact, they have an infection that's now become septic. So it affects our assessment, and then it affects our plan, really, in terms of a patient. We make an evaluation of how resilient somebody is based on basically on a 10, 15-minute evaluation in the emergency department, because it affects, are we going to have to admit this patient because they don't have the physical resilience to recover quickly? Are we going to be able to send this patient home? And you would think age would be a good marker, but it's a terrible marker. We see patients who've fallen in their 90s, have multiple rib fractures, and they look great, and they have social supports, and they have great physical resilience, and we feel comfortable sending them home. And I will tell you that if somebody looked at that chart later and said, you sent a 97-year-old home with 3 rib fractures after a fall. And so there are, resilience is not well documented. We don't have a good measure for it, but, it's a little bit like that Supreme Court saying, you kind of know it when you see it, right? On the other hand, we have 50-year-olds who are not as resilient, and we know even with that same kind of injury or less, they're going to need to be admitted because they're not going to be able to make it home. So it makes a huge impact on the care that we provide.
I think it's really interesting that, some doctors, we use this term called gestalt, or just like this overall, perspective that we have about the patient. And that's basically what you're describing, is that, some people come in and you're like, oh, this is definitely not going to be good. And others do. And sometimes you're surprised at the age of the person or how many medical conditions they also have. Gail, would love to hear from you. I know that you've had in your lifetime some challenges. Please, if you're willing to, share about your experiences of some of your own physical resilience.
I guess this helps, right? Yes. Yeah, okay. So, hello, my name's Gail. I am 74. I, in the past 5 years, have undergone partial mastectomy, chemotherapy, radiation. I've had 2 falls, a broken elbow, a broken foot. We all went through COVID. My husband and I both had it. He was hospitalized. I was not. We both recovered. And thank you. As a young person, I was always active. And then throughout my career, I was a teacher, which if you're a classroom teacher, you're pretty active. You know that, right? But then I went into administration. So then comes the desk, right? And so my body started to change. And I was not nearly as active as before. But in the past 5 years, really like towards COVID time, it occurred to me that if I wanted to reach my goal of 94, still doing the things that I wanted to do, I needed to do something for my body. And so I thank you for inviting me here. I came here because I have been active in several UCSD studies through Strong Foundations, et cetera, and it's made a world of difference. I can attest to the fact that even though I have fallen and I have broken bones, that I am up and about very quickly because I have maintained resilience. Folks, I didn't know what resilience was. It's a new word in my vocabulary. Actually, though, a friend of mine last week just said something to me about how resilient I was, and I thought, it's like you don't know a word, and then you hear it once, and then it's everywhere, right? And so the physical piece is so important. I just have to back that up. And it's never too late. That's the other piece. You can start small, and continue and find a way to do it that keeps you engaged. And that's another piece that I think is so important. As an educator, one of our mantras is what gets measured gets done. When I was trying to do this on my own, and even though I was motivated, it was so easy to backslide. But then when I found some programs where I had some accountability, where somebody was depending on me to be there at a certain time, doing a certain thing. So the physical piece, just find a place and a time and a person and accountability and find a way to get yourself stronger. So I guess that's my input as far as how all of my physical activities have improved my resilience. And I continue to do that now. I will continue to do it, and hopefully we'll reach that 94 and still be able to do all the things that I do now.
My grandma was 107 when she passed, so let's make that your goal. So it's part of physical resilience. Genetics clearly plays a part of that. I don't really want to make it to 107, but, there's definitely something there in our family. So I'd love to hear a little bit more discussion around what recent scientific discoveries about physical resilience as it specifically relates to older adults. So what are some recent things that have been interesting to you?
Thank you, and thank you so much, Gail, for sharing your story. What I would say is that just to echo what Gail said, it's a lot of what we're really understanding, I think, right now, or at least what's really interesting to me, is just really trying to not just meet people where they're at, but then also try to instill the delta that can be, what change can occur. And so what I'd like to really think about from a ground science standpoint up and how it translates to clinically, and then frankly, even more importantly, how does it resonate into communities in a way that meets people with the needs that they are expecting, such that there is a sustainable change and there is an iterative improvement. So how can people start to begin to improve, believe that they can improve, and then maintain, and then don't just plateau, continue to strive. So I would say maybe when you're 105, you won't feel 107 is too long, you know? So that's one thing. And then really stripping it down as well, if you think about what we understand about cardiovascular health and cardiovascular science, we're still learning so much. And we, the royal we, we've been studying this for 40, 50 years longer than we have musculoskeletal health, and how the musculoskeletal system interplays, not just from a skeletal structure standpoint, but even more importantly from a metabolic standpoint, from a plasticity standpoint, from a memory standpoint, to remember where center of balance is, to feedback to the brain and how that interacts with our environment, and all the different things that we have every single day that has added stress. So, to me, that's what's so fascinating. And then also exciting is measurement. So how can we start measuring things where people are living with how they're living in their own lives, and then understand, well, what are the things that you're already doing that maybe could be amplified, or the things that you're already doing that could maybe be mitigated, could be slightly changed or tweaked, that could provide some benefit based upon evidence-based and informed decisions. So, measurement is, I think, so important, because the science is getting to the place that we can start doing these things at home. We can start understanding physiology, and we can understand not just the physiology about things like blood pressure and heart rate, but also, as has been said in some of the previous speakers, the patient-reported outcomes. So what's important to people? What drives them? What are the things that are challenging for them? And then how does the physiology intertwine with that?
I'm just gonna want to comment real quick. So certainly, I think it's exciting that we have had some advances in how we measure physical function and physical resilience. But another cool thing is that it's become so much more accessible. So, for example, Fitbits, or just tracking your steps, even with your phone. How many people have access to that in this room? Yeah, almost everybody does, right? So these things are becoming more and more accessible, which enables physicians, to also look at some of that data and talk to you and provide very precise types of recommendations of like, oh, okay, I see you were doing you're doing a lot great with steps, but like maybe incline, or I didn't see your heart rate get up, sufficiently during that period of time. So it's kind of exciting to see how accessible some of these measurements are, and how we as physicians can use them to help our patients live better lives. Okay.
Sorry, real quick. I'll also say it's a phenomenal conversation starter, too, because sometimes people are saying, I don't really do anything, I don't really do very much. And you can say, well, actually, I can see you are. And that's a conversation starter to say, well, you're not actually starting from nothing. Everyone, generally speaking, everybody's trying their best. And most people want to do better, but it's really about saying, well, how does that occur? And what is it meaningful for them? So.
Yeah, no, I agree with everything. I think the exciting part about the science and the talks this morning, I'm about to turn 60 in a couple more months, and it's very exciting to hear about all these things, and you're all here for that reason. I think what's exciting to me in what I do is that in emergency or acute care, that's when the stress happens. And when I trained, if somebody fell and they broke their wrist, we take care of the broken wrist, but we don't take care of what's the underlying cause of their fall. And that has changed. I mean, you've heard from Dr. Molina about their geriatric emergency department. That is spreading across the country because we are trying to get to the underlying problems that bring patients to our emergency department. So I'm really excited about the application of all this new science and what we can do. I'll give one more example is one of the things that we do at the GE is do a nutrition assessment, a dietary assessment. When I trained, that would never happen in the emergency department. Can you imagine? Unfortunately, you stay long enough that we can do that assessment. But, we've sent patients for nutrition referrals, and I think it really gets to, one of the frustrations for a lot of emergency physicians is we keep seeing the same patients or patients recurrent to the same problems, and now we feel like there are now some tools that we can potentially address these things and prevent these kinds of occurrences. So that's what's exciting to me.
Just want to comment too on that briefly. So I don't know if you all have heard of this concept called patient-centered care or person-centered care. Sounds like that is now really the ER setting even is now really embracing this approach of look at the person before you. What do they specifically need to continue to be healthy and not come back to the emergency room? So I'm really excited to see how those things have grown. I too, when I was in medical school, went through the ER rotation, they were not, addressing all of these other factors that contribute to health. So it's exciting to see the growth in medicine in the U.S.
And I'm excited too to see the body-brain-gut connection that's coming more and more into the forefront because one of the studies that I did through UCSD was nutrition. And so, again, I'll go with the Fitbit or any other app that you can get to help you track, again, what gets measured gets done. If you write it down every day, then you know what you're eating, you know what variety you're using, and your gut biome is so important to help relieve those stressors. And, the brain thing, I was caregiver for my husband during the last couple of years of his life. He's since passed away, but that is an additional stressor. So that brain thing that's going on, you have to take care of yourself so you can take care of others. And it helped motivate me. And so the physical plus the nutrition plus the mental health, getting friends, going out, make sure that you're not isolating yourself. All of those things work together to build that resilient lifestyle, right?
We're getting a little bit into mental resilience here. But I just want to amplify that. I think in America, we have a culture in general that really values and celebrates independence, which is amazing. But that doesn't mean you can't ask for help and you should be solitary. And this is a thing for me as well. So my population of older adults with HIV, many of them are alone. The ones that are older, most of them lost most of their colleagues in the 80s and 90s to the AIDS epidemic. And so they're struggling. So thank you for mentioning that. And I'm sure we'll hear more about that in the future panel. We won't spoil by talking about it more. So the next question is, in the current field of physical resilience, and based on your own experiences, what are some ongoing knowledge gaps? What should we be looking at? What should we be pursuing in research?
What a phenomenal question. It could be in and of itself probably several days. And many of the speakers this morning, and I'm sure this afternoon, will really dive a lot more deeper into that. I think for me as a clinician, the things that are the most interesting is really thinking about the person as a whole, and how do we really create that snapshot to be able to measure, well, how are you today, and how are you next year, and where are you, and where do you want to be, and how has that been achieved or not been achieved, and why? But then also one of the elephants in the room, of course, is that one of the things that I do is prescribe medications. And there's a lot of role for these medications, but there's also side effects. And there's drug-drug interactions, and there's drug-metabolic interactions, there's drug-food interactions. And these things are sometimes well understood, sometimes very poorly understood. But the long-term implications and how that interacts with things like muscle health and mitochondrial health, I think is really poorly understood. It doesn't necessarily mean that, one study comes out and we say we stop prescribing this medication. Everything is about benefits and risks, but it also is about saying, well, where is someone right now and what is the best option that might meet them where they're at, to be able to achieve, again, the optimized health span that makes sense for them. As has been recognized, we all do things that we shouldn't do. We all sometimes believe and confess that we do things that we shouldn't do, but regardless, most of us, we're not trying to do it on purpose for some sort of self-deprecating or societally harm-driven reason. It's because we enjoy them, or because it's easy, or because there's just too many competing interests in the day, or there's stresses, or whatever. But so for me, it's really about thinking, well, how can we really think about how do we optimize someone's health? And then also acknowledge that some of the things that we're doing might not be the best option for them, but it's the best option overall. So, I think that really, just to answer your question finally, is I think drugs are really the thing that really fascinates me, especially, of course, GLP-1 agonists, right? So these are commonly prescribed and very beneficial medications that are increasingly being adopted for a variety of health conditions. But they do have some side effects, and it doesn't mean that they're bad medications. By and large, they're phenomenal medications, but they definitely detrimentally affect the musculoskeletal system. And how do we, therefore, not necessarily say, don't take the drug, but we say, well, what is the most optimized way to meet you where you're at, to make sure that as you take this medication, we can preserve as much of your health independence and resilience as possible?
That's an excellent comment about the GLP-1 RAs. There was a study in HIV that also looked at this specifically for liver, fatty liver, which one of the drugs now has an indication for fatty liver because it does decrease fat in the liver. And they did see decreases in muscle tone, as you're describing, or in muscle size, but functionally, it didn't seem like there was a big effect. But that being said, this population in HIV at least was younger, and I think the studies that are looking at sarcopenia or decrease in muscle size are probably older adults, and it's just harder to rebuild things and maintain function, because age does also impact physical resilience. It is one of those conditions. Dr. Chen?
Yeah, I think, you heard about it this morning in terms of the studies that Dr. Molina is doing in the emergency department in terms of the gap. We don't have a great measure for resilience, right? And age is a terrible marker for that. And so we're doing this study where we're looking, is it functional measures? Is it your grip strength? Is it your ability to stand and get up out of a chair? Or is it some mitochondrial signal that would say this person's very resilient and this person maybe has a little less resilience? That would then have implications on how we care for that patient when they have a stress. Like if you came in with a pneumonia and we had this marker that we said you're very resilient, you can go home with oral antibiotics. Or you have a low resilience marker or higher frailty index, you need to come to the hospital because you're at risk in the next 72 hours from becoming septic and you need IV antibiotics. That's where the gap is in terms of what we do is like we don't have good markers for resilience, and we know the implications for resilience and recovery and getting back to as high a baseline of function as you possibly can.
And so medically speaking, I appreciate both of your comments. I would say from my perspective, one of the biggest gaps is the implementation gap, because no matter what we know, if people don't know what to do with it and can't use it, then it does very little good. And so Dr. Moran spoke earlier, I think, about, or maybe it was just in conversation, so a program that through UCSD where they were assisting people to do some of these things at home in order to spread the capacity for more people to do the things that will help them become resilient. And so I think that's where we really need to focus a lot of energy, is spreading the word. You people, you're here, you're hearing it, so please go out and tell other people that they need to, everybody needs to up our game. That's it. And how do you do it? And it's never too late. And jump in. Let's get it going.
So I'm curious here, how many of you, raise your hand if this is yes, has your doctor actually given you an exercise prescription? Anybody? Okay. More than I was expecting. Okay. Do you
Adverse group here, maybe.
do you do that in your clinic?
So perhaps you're referring to the American College of Sports Medicine's Exercise Medicine campaign. So this has been around for about almost 20 years, I think, which is the idea that if clinicians understand where people are at, there can be actually an evidence-based and informed prescription, like a physical script that says, now do this to slowly improve over the course of time to ultimately achieve what largely is accepted. Again, speaking large epidemiological studies. And again, we're not talking about the N of 1 right now. So what I mean by that is that someone might only need 75 minutes a week. Someone might need 300 minutes a week. But looking at large groups of people, in general, 150 minutes a week of moderate activity, which is defined as basically slightly less than a brisk walk a week, plus resistance training, right? That's always forgotten about and extremely relevant today. So including improving strength training to improve overall cardiovascular benefit as well as in general aging in general. So I've dodged your question intentionally. The electronic medical record does not easily allow for prescriptions, though the conversations do come up. I will tell you, though, I am guilty that it's probably not nearly as robust as it should be in terms of being not, my bringing it up uniformly every single time. So,
if your doctor's prescribed you an exercise prescription, would you follow it? Do you think you'd do better about having more physical activity? What do you guys think? Yes? It looks like mostly yes. Okay. Sounds like we need to do more doctor education and maybe build something into Epic at UCSD. We probably need to get money for that, though. We'll figure it out. Okay, so my next question, and we still have some time. Based on the current science and your experience, what are the top 3 things / interventions that you would recommend to optimize physical resilience?
Great question. So the first one, not to hedge here again, since it seems to be a trend, but it's really about saying, well, first, where is someone starting? But like assuming that someone's starting from very little, emphasizing, first that there's clear interest in engaging in that conversation, that they're sitting in front of you because someone wants to do better, because that is a conversation starter, right? So some of the really high-yield things that, I think everyone can really start regardless of where they're at are things that really focus a lot on the lower extremity strength, but then also the upper extremity strength, and at the same time emphasizing postural alignment and balance training. And these things all can be done at home. So sometimes I'll talk to patients and we'll talk about exercise, and it'll like dogmatically lead to, oh, well, I have a gym membership. Oh, I guess I could get a personal trainer. And yes, that's true, but that's not necessarily going to achieve what's going to ultimately improve your function, because most of these things can occur at home, and meeting people with what drives them. Are they a social person? Do they need that social network? Are they someone that kind of wakes up in the morning and just kind of wants to get it done? Is it the kind of person that says, what's the very minimum that I can do, right? Or, which is a very, I think, I don't want to say American thing, but it is a. But really meeting where they're at, and then to say, well, some of the things that are really, really high yield are things like chin and heel rises. So these are things that really strengthen a lot of the lower extremity, including the ankle, help with making sure that there's tripping. 60% of falls occur at home. Making sure that we optimize the body as much as we can to interact with the environment. That's a whole independent thing. But then also chair stands. So, starting from a seated position, if you need it, you can use the sides of the chair. If not, and then just counting as many as you can get. And keeping that standard and then slowly working to increase it over the course of time and making it part of a daily routine. Wall push-ups. Wall push-ups are enormous because oftentimes, unfortunately, people fall and they can't get up, right? So we can't ignore our upper extremity. And not just that, generally, I won't say all of us, but many of us, I'll speak for myself, we live at a computer like this. And what this does over the course of time is it shrinks the muscular system on your anterior chest. So physically, it's shrinking. Meanwhile, you're slowly contorting and you're contributing to the clinical syndrome of kyphosis. So your cervical spine and your thoracic spine is starting to bend over. And this gets accentuated, of course, when there's injuries, of course, when things occur, but just in general, oftentimes practices that we do every single day, sitting at a computer and watching screens. And I'm quite guilty, so I'm not pointing a finger here. Push-ups, so wall push-ups if you're not able to do a ground push-up. So standing against a wall, going in and pushing out. This really opens up that chest, also works that the upper back muscles as well as the cervical spine and chin tucks as well. Because we forget about our cervical spine, of course, which is what connects our head to our body. We forget that there's muscles that hold the head up, and many of us kind of look down all the time. But looking straight forward, enormously important, not just for postural alignment, which is independently a risk for falls, but also for being able to see the world around us, because vision is critical for our ability to maintain function as well as prevent falls. So,
well, I'm going to sit up now here. Just kidding. These are all great points. I know this panel is about physical resilience, but the connection between physical resilience and cognitive and mental and social resilience is critical, right? I think increasing, you can think about doing all these exercises, but in my mind, they're kind of boring and after a couple of days, they'll drop off. But if you're socially engaged with a walking group, or you're socially engaged with a group that does yoga on a regular basis or Tai Chi, that will get that physical resilience. So, in my mind, that is a key element, is the social support and that network to bolster the physical resilience and the activities that help bolster physical resilience.
And just piggybacking on what both of you said is the accountability piece. So as you said, some people have internal accountability. If you do, great. But how are you tracking it? If you need that partner, find an app, find something to hold you accountable to doing it every day, to making it part of your life. And then also the social piece, the mental piece, and the other thing that I would say is nutrition. If your body doesn't have correct nutrition, you're not going to be physically strong. And so it is all tied together. So find a way to make sure that they're eating correctly and that you're giving your body the variety of nutrients that it needs, as well as not overtaxing by putting too much into it. I'm guilty of that a lot, but I'm trying not to be. So, yeah, and what gets measured gets done. I can't say it enough.
Gail, as an anecdote, so I don't like to make multiple trips from the car to the house after getting groceries. And so I will literally carry like 5 bags of groceries into the house. And my husband's like, what are you doing? So I hear you. So we have a little bit of time to kind of explore this last question before we take questions from the audience. So if you were a city planner with physical resilience in mind and had an unlimited budget, what are some policies that you would advocate for as it relates to funding for public programs across health, education, economic stability, optimization of the built environment, and fostering of healthy community connection?
So, great question. And again, a PhD in career unto itself, which many have done at UC San Diego and San Diego State and many other universities as well. But what I would say is just really emphasizing active transportation. This is something that we do, generally speaking, don't really do in the United States. So, there's been a lot of attempts at this at different communities. So mixed-use development has been one of these. And whether or not that's fallen short or whether or not that actually has met those needs is an independent discussion, but just really thinking about active transportation. So what I mean about that is, using your body to get from point A to point B, to improve your social connections, to making sure that you're part of the community, to making sure that you're using your body to continue to interact with the environment in a steady pace. So active transportation is critical in how that's achieved. I don't think there's a single best answer to that. It really is, well, what are the societal values and what is important culturally and frankly also within specific age groups, right? Because there are different needs. So, and then that's a really tough thing, of course, to achieve, but you gave me an unlimited budget, right? With a lot of engineers and no environmental impact reports, et cetera. But what I would also say, though, is that last mile is also something that's really hotly studied. And what that means is that even if you're going to drive somewhere, parking a little bit further away. I mean, every little thing can add up. So you don't, I think, need to reinvent an entire city to still take some advantage of what we already know, which is, the more you use your body to engage in active transportation, the better.
I agree completely. I think, from a societal level, the people in here are probably the people we're least worried about. You're spending a whole day here, right? If you walk 2 blocks that way, you have large homeless encampments. In the point of count study that's done every year in San Diego, the fastest growing group of homeless are older adults. Those are the population and society needs to be worried about. And the resources around that, there are resources, but they're not really well distributed, number one, and very uneven. For example, there are senior centers, all over, there are 12 or 13, but they have varying quality and varying engagement with the community they are. So, resources around community engagement, resources reaching out to what are known as senior orphans, right? And then we have to talk about the caregiver community because that is a tremendous expense, and that many of you probably, a lot of it happens under the table. And that is, we're going to need more of that. Unless the robots get really good really fast, we're going to need a lot of that in our society. So those are the things I'd focus on.
Those are great things to focus on. So let's add some community commons. Let's have places in every neighborhood where people can come together and they can garden, they can have a physical fitness space, they can have social interaction. So, if we've got all the money in the world, right, why can't we do that? And then you talked about the transportation piece. So make every neighborhood walkable, make every building accessible. That's another piece as well. So just giving people a place where they can be in communion with each other and express those social needs, as well as being physically active. So I think those would be like the mixed use kinds of neighborhoods.
And perfect for San Diego because we don't get ice, right? So we should be doing these things, right? Okay, we are at the question and answer period of time. Anybody have questions?
Yes, I have some questions collected already. If you have questions, just go ahead and send your card over to one of our staff. But we're going to start with a question for Gail. Gail, thank you so much for sharing your personal story and your experience. You mentioned that you signed up for the Strong Foundations program at UCSD. I'm wondering if you could give advice to somebody that probably thinks they could benefit from that program, but might feel a little bit reluctant, maybe nervous, apprehensive to go out of their comfort zone and try something new like that, which can be hard for people.
I cannot say enough good things about all of the people that I met through UCSD's Strong Foundations. I am still in contact. I started there in 2022, probably. I haven't done a program with them for over a year, maybe, but Shoshi, the person that was one of my contacts, reached out to me for this because she and I had developed a relationship, and that's the way it is. They are there for you. They make everything accessible. They make everything easy, and there's no stress. There's no pushing. It's like, and everything that we did always had modifications available. So if you can't do it this way, then this is the way that you need to do it so that it's the best benefit for you. Please don't be afraid. Please reach out. Please do it. Jump in. All right? The water's fine.
I love it. Thank you so much, Gail. Okay, this is a question for any of you on the stage. What are some activities I can do with my family to improve my own resilience?
I think it just depends on what's important to your family and what your family is doing. What I would say, though, is that anything that involves any sort of activity is a huge added value. So, I think it strengthens the family community. I mean, it's not just my opinion. This is generally accepted, but it strengthens the family community. It also can improve making sure that there's, active relationships, which is really important for aging. So, any sort of activity that is centered around the family that, depending upon if you have grandkids or kids or cousins, brothers, et cetera, but making sure that there's some sort of outing. So if that means going for a walk, going for a hike, going to the park, but just making sure that you're especially if you're here in San Diego, taking advantage of the outdoor space as much as you can. So.
And I would say plan for it. It's not going to happen spontaneously. So talk with your family. Ask them what they want to do. Give them choices. Let the kids make the decision of what they're going to do today or next week. And then variety so that we don't get bored with it. But having a family plan where everyone's going to shut off their electronics, we're going to put it all down, we're going to go outside and take advantage of this wonderful place where we live.
So I have a 73-year-old mom who's still working as an elementary school teacher. I don't know why she's still working, but she loves her job, just like I love mine. I have a 10 and a 13-year-old who basically are obsessed with video games and TV because, unfortunately, that's kind of what their culture has been doing. They went through COVID, and so they are just used to being in front of screens all the time. And in order for my mom to engage them, she actually, when she comes and visits, she takes them to Belmont Park. And she will ride roller coasters with them. When we go to Hawaii to visit them, she takes them to the water park, and rides these like crazy toilet bowl type water things with them. So, if you continue to have excellent physical resilience and, when you're in your mid 70s or even older, maybe you can still take your grandkids to do these things that they really want to do and they get super engaged in. And maybe they wouldn't expect their grandma to be or their grandpa to be the person that's taking them on all these things.
I have a season's pass to Belmont Park.
Oh.
Okay, Belmont Park, everybody. Meet you there.
Let's all head there after this. Okay, we have time for one last question. Are there non-exercise interventions that can decrease fall risk?
I can talk to that.
Yay.
Yay. And I don't think you would call it exercise, but one of the things that we did through some of the studies that we did was focusing on balance. And so when you're brushing your teeth in the morning, stand on one leg. Once you can do that effectively with either of your legs, take a pillow, stand on the pillow. It sort of changes, it changes things. So, and then start doing other things while you're standing on one leg. I know that sounds kind of funny, but if you're brushing your teeth or if you're writing with your other hand, but focusing on balance is going to help you also mitigate falls.
Okay, we have another question for you. Oh, go ahead, Dr. Moran.
No, that's okay.
No, we would like to hear from you on this one.
I would just absolutely echo that, but then I would also say, you can also change your environment to make sure that you're engaging a little bit more. So about 5 years ago, I started a shared medical appointment, which is a group visit centered on fall prevention, because we just were not, in my opinion, doing enough clinically to really discuss the science behind fall prevention and making it meet people where they're at. And through that, years ago, someone did mention that they did this, and I'm not endorsing it, but they said, what I do is I change the mirror in my car so I have to sit up so that I can see when I drive. And so, I think that's maybe not, again, I'm not like advocating that you should do that. But what I am saying is what you can do is you can change the environment such that, it's less easy to do the easy things that we all do, like watch TV all the time and, be on the computer. So.
Yeah, I have a stand-up desk, and I have a treadmill, like a walking treadmill, so that I can walk while I'm in meetings and stand. And I don't know if that's going to help my balance, but it's a way for me to get more exercise and not always just be on meetings all day.
If I can just say, it would be irresponsible if I didn't say this. Listen, if you're going to stand on one foot on a pillow, make sure you're holding on to something, because I don't want you to come into my emergency department with that story.
You're not supposed to do it. You don't do it until you get really good at only standing on one foot.
And Dr. Chan is going to say, you are sent here by Gail. There's a large influx in the emergency room.
Gail will blame me.
That's right. Okay, another question. This is for any of you on there. Any supplements that support physical resilience? Anything you know about?
Again, I think this was alluded to earlier. It's a huge area of interest, and Dr. Molina has a very active, ongoing study. If you're interested, please consider contributing to research. What I would say is what we do know, though, is that in general, older adults often don't get enough protein. So 1 to 1.2 kilograms, grams per kilogram of body weight is what's recommended to combat sarcopenia, or the clinical syndrome of low muscle mass, in combination with resistance training. So in addition, most older adults, so most people probably benefit, unless you have a very dairy-rich diet, supplementing with calcium, plus or minus vitamin D, depending upon your specific discussion with your clinician. So these are fairly well grounded. Now, multivitamins have been studied in a different context, and some studies have shown benefits, some have not. Vitamin E's been studied, vitamin A's been studied. I mean, there have been a lot of studies, but largely, I think what's really important to emphasize is the pervasive science is that no to limited processed foods, generally plant-focused foods, generally limiting animal products confers benefit.
It is hard, though, if you are pure vegan, to get that protein in. It is a lot of protein-type food that you have to eat.
It absolutely is, and I will just quickly plug here, an Oreo is vegan. So, labels... labels are one thing, but it really is about the choices that you make, so...
That is so good. Okay, now I'm going to eat more Oreos today. Well, another question about diet, since you were just talking about it, is the keto diet healthy and safe for an older adult?
These are good primary care questions.
Yes, let's punt this to Dr. Karris and Dr. Moran.
So I think it's hard because there's so many different variables, so older adults tend to be more at risk for cardiovascular disease because you've lived long enough that most everybody's going to accumulate some calcium in the arteries. So sometimes a keto diet can be very fat forward, and that is not always a good thing. In general, I still recommend an overall balanced diet, that is as as much plant-based things that you can get, but also trying to achieve the goal for protein as well. But I think my population is a little bit more socially challenged and can't always get access to good foods. So for them, I worry more just about like how much they're eating and if they're eating enough calories, which is also important. I think, and unfortunately, even though we get older, we don't always lose this ideal of this skinny model type person as a woman. And I have some older women a lot of my older women still complain about, like, oh, I think I need to lose more weight, this or that. And at some point, I think we need to just start throwing that away and focus on being healthy and eating a healthy diet. Because if you are not eating enough food and you're not eating enough protein, that increases your risk of things like fractures, falls, and all sorts of other stuff.
I would echo that. And I would also say, I think it's always important to start with saying, well, what's your goal? Because sometimes people are saying, well, it's to lose some weight. But then what? Like, unless you're willing to do this forever, there's really no reason to do it now. Because if you do it and it works and you stop, you're going to gain weight back, all else equal. So it really is saying, well, why are you doing this? And if it's for health, then I would say, well, generally speaking, there's probably better ways of achieving what you want to achieve than that specific way of doing it. So I think it just depends on the context as to why it's occurring. So.
Okay, and this is our absolute last question. I'm just stalling a little bit because catering is not ready. So if you're wondering why, there's a reason. Okay, last question. How can I improve my stamina? Anybody on the stage?
I guess question number one is, are you sleeping? Because, a lot of folks struggle with insomnia for lots of different reasons. In truth, medications for insomnia most of them are really supposed to be short-term, not for the rest of your life. Probably the best cure for insomnia is cognitive behavioral therapy. And there's some apps for that, if any of you guys have iPhones. And so that is one thing that I think, people are tired because we're not getting restful sleep. And there are many medical conditions that can contribute to that as well. So like sleep apnea, for example, restless legs, which could be a symptom of anemia. So I would recommend really exploring, what is behind the fact that you are just tired or just feel like you don't have stamina all the time, first with your physician, because there may actually be something going on that we can help fix.
I would also say, measuring it too. So, and whatever that means to you, because otherwise I think it can be very challenging to really understand when you're saying that there's a lack of stamina and or fatigue, if that's the same thing that you were asking, which is the more kind of clinical situation that I engage with, then it's really about saying, what does that really mean to you? Like, what are the things that you can't do because you're fatigued and or you have no stamina? And then where do you want to be? And then figuring out a way to measure that. If that's self-reported, things like sleep journals or things like, or step counts, for example. But being able to measure it's really important as well. If that really is one of the big things that you're really invested in understanding.
And in the Jerry world, we're big on this concept called deprescription. And sometimes a lot of the medications make people feel not great. So, regularly reviewing with your primary care provider, do I really still need to be taking all these medications? May sometimes be a good practice as well.
Yeah, I think it's all the things we've talked about today, right? First, make sure there's no medical issue or nutritional issue, but then it's engagement and exercise and activity. And don't push yourself too hard, because I think if you slowly build up to it, right? It takes time, but it's all the things that we've talked about today, really.
I think that's such a key statement. It takes time. Don't expect yourself to climb Mount Rushmore the first day that you go out hiking. So it's a slow and steady, but continue. Don't give up. Give yourself grace, and just keep climbing that mountain, and you'll get to the top.
Well, thanks you guys so much.